Hello friends, my name is Dr. Rahul Sethi. I'm MD Internal Medicine. I'm fellow in Critical Care Medicine and I'm also fellow in Intensive Care Medicine. I'm MBA Hospital Administration. I'm member of American College of Emergency Physicians and member of European Respiratory Society. I'm honorary member for Emergency Medicine Association of India and I'm also the ACLS and BLS instructor. This video is being sponsored by Delhi Institute of Advanced Medical Sciences. Special thanks to Mr. Rajesh Sharma, the director of the institute. And today I will be teaching the heart failure, which is a very common topic and which is being understood by few. So today we'll try to make the concepts of heart failure easy for you so that you can understand. So let's start our topic. Heart failure, guys. What do you understand by heart failure? So heart failure is basically when the heart can't supply blood according to the body demands, right? So heart failure is basically of two types: systolic heart failure and a diastolic heart failure, right? So systolic heart failure is basically the heart failure where the heart can't pump, right? Can't pump the blood, right? But in diastolic heart failure, what happens is when the heart can't fill itself properly, right? So systolic heart failure, when the systolic function, when the heart contracts and send the blood to the whole of the body, is being compromised. And in diastolic heart failure, where the heart cannot fill the blood properly and send the blood to the whole of the body, right? So what happens is when there is a systolic failure or a diastolic heart failure, what happens is that the blood, because of compromised pumping or compromised filling of the heart, is not able to go to the other part of the body. It goes back to the lungs and the blood goes into the lungs and causes congestion in the lungs, right? This causes congestion in the lung, and that's why this heart failure has another name, which is known as congestive heart failure, because of the congestion in the lungs of the blood, right? So basically millions of death right, occurs because of heart failure every year, and this has been a great, financial burden on the government of various countries, right guys? So guys, we need to understand the ejection fraction, right? To understand ejection fraction, what we need to understand is basically a cardiac output. So we all know that cardiac output is basically the stroke volume into the heart rate, right? Stroke volume is in milliliters into heartbeat, which is in beats per minute, right? So let's say if the stroke volume is around about 70 ml into round about, let's say the heart rate is also 70 beats per minute, it is round about 4900 ml per minute, which is approximately what, 5 liters of blood per minute, which is a cardiac output, right? So if let's say this is our heart and this is the aorta, let's say when a single time when the heart contracts, the amount of that blood which in that single contraction is getting out of the heart is basically known as stroke volume, which was around about 70 ml, right? But the total volume in the heart remains a bit high, and not in a contraction all that blood which is there in the ventricle goes out, and few milliliters of the blood remains in the heart, right? So let's say if the total volume was, let's say 110 ml, right, and the stroke volume was around about 70 ml, right? So what would the percentage which is going out? Let's say, let's calculate guys. So 70 by 110 into 100, right? Ejection fraction. This is round about, let's say 64%, right guys? If you do the mathematical calculations, it will be around about 64%. And this is what is called as ejection fraction. Now I'll take you to a small scale where this I have marked as 70, this is around about 50, this is, let's say 40, okay? So from 50 to 70%, this is the normal ejection fraction. From 40 to 50%, this is basically a borderline systolic heart failure, and less than 40%, it is all systolic heart failure. Okay guys, now most of the time ejection fractions help us to diagnose the systolic heart failure. Okay, because in systolic heart failure always the ejection fraction will be low, and then we can diagnose it as a systolic. Okay, so diastolic heart failure. In diastolic heart failure, what happens is, let's say this is our heart, and now you know that diastolic heart failure is what? In which there is no proper filling of the heart, right? So there will be no proper filling of the heart, so the total volume will be less, right? And when there will be no filling, there will be no proper output, right? So both the values, the stroke volume and the total volume, will be less. Let's say the total volume is 69 and let's say the stroke volume is 44 ml, right? In this case, what happens is, because both the values are getting down, your ejection fraction will not be affected. It will be normal. So if I do this calculations into 100, it will be down to about again 64%, right? And you can see in the diastolic heart failure, we have the ejection fraction in lower numbers, right? In the lower percentage, and that's why how we diagnose it. But in diastolic heart failure, it is same, because both the values, the stroke volume and the total volume, they're getting lower, right? So this is not a very good option for us to diagnose the diastolic heart failure. So this is a very important concept which you need to understand, that this is the reason why the ejection fraction in the diastolic heart failure is maintained, though the heart is failing. Okay. Now, I would further like to take you to another concept. Diastolic heart failure is basically also the abnormal filling, as you all know, and this abnormal filling is basically also reducing the preload, right? So preload is decreasing, and that's why the total volume is also decreasing. And when the total volume is decreasing, of course the stroke volume will be decreasing, right? Stroke volume is also decreasing, and because these both two values are decreasing, they are not affecting our EF, right? So that's why the EF in diastolic heart failure. Now there is a relationship between diastolic and systolic function, right? And this relationship is being explained by a very well established law which is known as Frank-Starling law, right? So what does the Frank-Starling law tells us? It tells us basically a graph should be plotted. A graph is like this, right? And this is our x-axis, this is our y-axis. So the y-axis is basically the ventricle filling, which is a diastole, right? And then we have a stroke volume, which is our x-axis, and this is basically a systole. So you know the Frank-Starling relationship between the diastole and the systole function has been well explained by Frank-Starling law, where I have two axes, the y-axis which represents the ventricle filling, and the x-axis which represents the stroke volume. For example, this is systole, and ventricle filling, which is a diastole. So Frank-Starling mechanism is basically an adaptive mechanism by which an increase in preload enhances the cardiac performance. Okay. So guys, as we have understood that there is a systolic heart failure and we have a diastolic heart failure, similarly our heart has four chambers, right? The right side and the left side, right? So we have the left ventricle and the right ventricle. So we have, on the basis of that, we have a left side heart failure and a right side heart failure. So let's talk about the left side heart failure today. Okay, what are the reasons for left side heart failures? let's discuss one by one. So usually I would like to tell you that usually the left side heart failure is usually systolic in nature. Usually it is systolic in nature, guys. Okay, and what are the different reasons of left-sided heart failure which is usually systolic in nature? So the first very common reason for left side heart failure is infarction. Okay guys, the first very common reason is infarction. And what does infarction do, guys? So what does infarction do is basically it damages the myocardium. Okay, so let's say this is my heart and this is somewhere where the infarction has taken place. Okay, so for this place where the infarction has taken place, from there my myocardium will become weak. Sometimes what happens is that the infarction damages the myocardium in such a bad way that a scar tissue is developed, and when the scar tissue is been developed, guys, what happens is the contraction ability of the myocardium is lost. And that's how, if the infarction is massive, it can involve a large piece of myocardium of the left ventricle, and of course the systolic function will be common. Let's say, so left side heart failure, guys. Second reason is, let's say, long-standing hypertension, right? So what does long-standing hypertension do, guys? What does long-standing hypertension do? So in long-standing hypertension, what happens is that the arterial pressure in the body becomes more as compared to the pressure in the heart, right? And that causes the heart to function more to supply the blood to the body. And that causes, basically, I will write first, the atrial blood pressure increases, guys. Okay, this leads to the pressure, the atrial blood pressure increases in the body, which leads to the heart to work more to overcome this pressure to supply the blood to the other parts of the body, and that leads to the hypertrophy of heart, right? This hypertrophy, basically what does it do? It leads to basically enlargement or increase of muscle mass of the heart and also the O2 demand, right? It basically leads to what? Hypertrophy of the heart leads to the increase of the muscle mass and also the O2 demand, right? And when this hypertrophied heart starts to work more to overcome the oxygen demand and also to supply the other parts of the body with the oxygenated blood, it leads to the weakness and thinning of myocardium, right guys? It leads to the weakness and thinning of myocardium, causing the left side heart failure. Myopathy, guys, another reason for left side heart failure is dilated cardiomyopathy. What does happen in dilated cardiomyopathy? The filling, because of the dilation of the chambers, the size of heart chambers increases, right? It increases. So now when the size of the heart chambers increases, the filling increases. In relation to the increased filling, the contraction also increases. Contractions also increases, right? And that leads to the weakness plus thinning of cardiac walls. And that leads to the left side heart failure, guys. Okay? So now, there is one more important thing which I would like to tell you is, see, I was discussing long-standing hypertension where I told you that left-sided heart failure is usually systolic. But one thing which I would like to add over here is, which you will not find in most of the books and in most of the lectures, is that long-standing hypertension, which is the reason for left-side heart failure, which is usually systolic, can be diastolic as well. Yes, you heard it right. You know, the left-sided heart failure can be diastolic, okay, and can be the diastolic left-sided heart failure can be because of long-standing hypertension. Yes, guys. So I will explain. So left-sided heart failure, which I told you is usually systolic, and one of the reasons for systolic left-sided heart failure is long-standing hypertension, guys. I would like to tell you that left-sided heart failure can be diastolic and can be because of long-standing hypertension. Yes, you heard it right. The long-standing hypertension can be a reason of diastolic left side heart failure, which you will not find in most of the books and most of the lectures. So today I would like to explain you that how does it happens. So diastolic left-sided heart failure because of long-standing hypertension, guys. How does it happens? So see, what happens is because of the long-standing hypertension, concentric hypertrophy of the heart takes place. In this, what happens is the sarcomeres, the number of the sarcomeres parallel to each other, they get increased, okay, and that leads to the less room for filling, okay. So the concentric hypertrophy, where the sarcomeres they get increased parallelly to each other, and that basically increases the heart wall mass, right? They basically increase the heart wall mass. That leads to basically decreased filling. And you know the basic concept. When the heart is not properly filling, it is a diastolic type of heart failure, right? And the long-standing hypertension, which is leading to the concentric hypertrophy, where the sarcomeres are increasing parallelly to each other, they increase the heart wall mass, that decrease the filling. And this is how the long-standing hypertension can also cause the diastolic heart failure, left-sided heart failure. And concentric hypertrophy can be because of, here I will just tell you two things, aortic stenosis, and can also be because of genetic factors, where we have the one disease because of genetics, that is known as hypertrophic cardiomyopathy, which you also known as HCM or HOCM, which is known as hypertrophic obstructive cardiomyopathy, which can be because of genetic reasons, guys. Okay, so guys, as we saw that there are different reasons for left-sided heart failure. Usually it is systolic, but because of long-standing hypertension it can be diastolic, right? Similarly, what happens is when the left side of the heart is not able to pump the blood properly, hypoperfusion, okay, hypoperfusion of our kidneys takes place. Hypoperfusion of our kidney takes place. And when there is a hypoperfusion of our kidneys, what happens is when the blood flow to the kidney decreases, what happens? You all know that this is very common. RAS system is activated, right? RAS system is activated. Renin, angiotensin, aldosterone system is basically activated. That leads to what? That leads to fluid retention, guys. That leads to fluid retention in the body, right? That leads to fluid retention in the body, and that fluid retention causes what? Causes what, guys? Causes the increase of the filling, increase in the filling in the heart, and when the filling will increase, preload will increase, right? When the preload will increase, what will happen, guys? When the preload is basically increased, the heart needs to work more, right? Needs to work more. That means contractions will be more. Contractions will be more. Heart will be working more and more, though it is in a heart failure state, but still it is trying to work more and more. What will happen now? Now the blood will start to leak from vessels, and what will happen, guys? Edema will develop. Edema will be there because of the blood which will be leaking from the vessels, causing the edema. And this edema you can see in all over the body in form of puffiness, right? Furthermore, what happens is basically this all extra blood which is coming in the heart will go back into the pulmonary veins. The blood will go into the pulmonary veins, right? So the pulmonary veins plus capillary beds. So the blood will go into the pulmonary veins plus capillary blood. That would increase the pressure in the pulmonary arteries. The pressure in the pulmonary arteries will be increased, and that would lead to the pulmonary edema. This is not pulmonary embolism, this is pulmonary edema, and that is what is known as congestion, right? And that's why we call it as congestive heart failure. Now guys, what happens is this will give us the various symptoms of our respiratory type in cardiac failure, and that would be dyspnea, orthopnea, right? Crackles, right? Crackles or rales. Now how does this develops? When there will be a pulmonary edema, guys, what happens is that this pulmonary edema is developed. How? Let's check it out. This is an alveoli, right? And this is a capillary which is passing by. Now this capillary has lot of congestion, right? And now this congestion, which is not normal, will lead to the fluid accumulation which will be there in the alveoli. And now because of this fluid accumulation, the gas exchange of O2 and CO2 will be very difficult. It will be very difficult, and that would lead to dyspnea, orthopnea, and crackles and rales, and dyspnea. And now the guy which has the edema, when he lies down in a supine position, the fluid in the body comes up, and that coming of the fluid leads to the more congestion in the lungs, and that congestion further and that worsens the symptom. So this guy, when he will be in a supine position, when the fluid will go more towards the lung, will worsen the situation, will worsen the symptoms, and that will cause more breathlessness, and that is known as orthopnea. Now sometimes what happens is that this alveoli which is there with the capillary, sometimes what happens is this capillary gets ruptured, and the RBCs, they enter the alveoli. Now what happens is these RBCs which enter the alveoli, they are being eaten up by the alveolar macrophages. They are being eaten up by the macrophages. So these alveolar macrophages, they eat up these cells and take these cells which have brownish color from the iron building, okay? So these RBCs, they have the brown color because of the iron building, and they have been eaten by the alveolar macrophages. And these alveolar macrophages, they are also known as, after eating the RBCs, they are also known as hemosiderin alveolar macrophages or heart failure cells. Because this occurs because of the heart failure, they are also known as heart failure cells. This question can be asked in your exam. It is a kind of question this is a kind of information which is not being given in most of the classes, most of the books, and most of the lectures. Okay, so this is known as heart failure cells. Now let's talk about the treatment of left-sided heart failure. So the choice of treatment is always ACE inhibitors. You know all the prills, right? All the prills, right? Basically ACE inhibitors, they work on the RAS system, as well as they help in stopping the remodeling of the heart. They stop the remodeling of the heart, guys. Okay? Now, the second choice is, of course, not the second choice, but the plan of treatment also includes diuretics. You know, diuretics basically take out the fluids from our body, right? We have different types of diuretics. So that we have edema in the body, so we need to give the diuretics so that the fluids can be taken out of the body, right? We also give beta blockers, of course the cardioselective ones, cardioselective beta blocker. So there is one new drug which is ARB plus neprilysin inhibitor, which is valvasartan plus sacubitril. But sacubitril, ARBs plus neprilysin inhibitor, the ARB is valvasartan and the neprilysin inhibitor is sacubitril. Always remember the sacubitril is basically a prodrug. Okay, so it gets into the body, gets converted into sacubitril. I will just write the spelling. So it turns into sacubitril, okay, and this is the drug which works in the body. So sacubitril is drugs. You remember that prodrugs are the ship drug, right? So this was sulfonamide, right? So please add with this sulfonamide sacubitril as well, okay, somewhere in your corner please add this as well. So the new drug ARB combination with neprilysin inhibitor, that is valvasartan plus sacubitril, which is a prodrug, gets converted into sacubitril in our body, and that basically helps us to overcome our heart failure. Now somebody will ask me, because this is a new drug recently been approved by FDA, some people will ask me, sir, what is this? What is neprilysin inhibitor? So I would like to tell you, basically neprilysin is a neutral endopeptidase, and it is zinc dependent metalloprotease, metalloprotease enzyme, and it inactivates basically several peptide hormones, including our dopaminergic system. So if we will inhibit this, our dopaminergic system will not be inhibited, and that will help our heart to function well, right? So this is a new drug which is coming with the name of Vimada, or there is one more pharma company which is making a drug of this combination, is known as Entresto. I am not basically advertising any kind of the trade names of the drugs. It is just for your information, because these are the two names with which the drugs are available in the market. So I'm not trying to basically advertise any kind of the trade names, okay? So Vimada and Entresto, they are basically recently approved by the FDA. So this is the treatment of the left side heart failure, AC inhibitors, all the prils, diuretics, beta blockers, and there is a new drug which is a combination of ARB plus neprilysin inhibitor, valvasartan plus, this is a combination of valvasartan plus sacubitril. Sacubitril is a prodrug which converts into the sacubitril inside our body and functions. With this, I finish the left-sided heart failure, and for the right-sided heart failure, I will meet you in my next video. I would like to thank the DIAMS, Delhi Institute of Advanced Medical Studies, and also the director of the DIAMS, Mr. Rajesh Sharma. Thank you for watching me.